And arguably, possibly one of the toughest things to deal with. So this is the extensor deficiency, and these are my disclosures that have no bearing on this talk. So extensor mechanism disruption, either during or after surgery, is a devastating complication. Happens between, it's not common, thank God, between 0.1 and 2.5%. And the chronic patellar tendon disruptions alone account for less than 1%. But when you do see these, it's almost a nightmare to deal with it. The etiology is usually traumatic, but can also be seen in patients with rheumatoid arthritis, SLE, diabetes, and chronic steroid use. Iatrogenic ruptures, particularly for when you do manipulations of the so-called knees that are stiff and early enough, sometimes you happen to partially transect the patellar tendon while using your oscillating saw, doesn't get detected, and then over the period of rehab and attempts to increase the range of flexion, you get this. So there are several systemic factors like rheumatoid, diabetes, chronic renal failure, obesity is one of the major risk factors. And then you have the local risk factors like prior knee surgeries. You heard this in the first talk. Multiple steroid injections, lateral retinacular releases. So we can have this at the level of the insertion of the patellar tendon, fracture of the patella, quadriceps tendon, transection of the patellar tendon. But like I said, patellar tendon is probably the most devastating of all of these that impacts both implant function and survivorship. So the available option is non-operative with a hinged brace. This is almost a nightmare. Most patients give it up. Repair options with sutures, staples, wires have poor results. Augmentations have been described, and we'll talk about that. And finally, the extensor mechanism, allograft and autograft. So quadriceps tendon ruptures are usually caused by manipulation in a stiff knee, and if you get this, it's really quite simple. If you happen to have to notice this or diagnose this early, just go and do a direct repair. Sometimes you might need to use augmentation. And if there is a complete full thickness graft, full thickness tear, use a allograft, which sadly we don't have, so there are alternate methods available. But one thing I would want to say is you must immobilize these in full extension for at least 8 to 10 weeks. So the early patellar tendon ruptures historically had poor results. These are some of the very early outcomes and reports. Turned on quadriceps flaps, again, very, very poor results. Alan Hansen and Brown from Mayo reported their outcomes with the Malex mesh. This is a nylon mesh that's used in hernia repairs. They reported good results at 2011 and subsequently after that. Other allograft options are Achilles tendon allograft and extensor tendon allografts. These are good options. Sadly, we don't have access to a lot of these. And again, when you see the earlier results from Bob Booth's group, the earlier reports, what is important that what changed was the fact that the graft in the earlier groups was not maximally tension, so they allowed for about 15-20 degrees of flexion at the time of the repair, versus a maximally tension, which is actually putting these grafts into a hyperextension, and the hyperextended group had good outcomes and results. So the best results actually were reported by using extensor tendon mechanism allograft. And again, when you see the reviews in literature, they talk about extensively immobilizing this in full extension. So these are all the various articles that are available. Extensor tendon has a high morbidity with fair results and high complication rate. So allografts by themselves do not have a great option. Soft tissue augmentations are really very poor. As I said, Brown and Alan Hansen's group has a 30% failure rate, and you need to immobilize this. So repeatedly, extension immobilization. Again, Matt Abdul, more recent reports of their repairs. Again, high complication rate. So really there are no good options and outcomes using these synthetic grafts. We actually reported our technique and reported this in Journal of Knee Surgery, where we use a quadriceps tendon with a patellar bone. This is one of our cases. And we reported this in the journal. We have done now 21 cases where we take a strip of the patellar tendon with a block of the patella. We insert that patella into the tibial tubercle, divide the tendon into two tails, loop it into the patella through a tunnel approach, and use the semitendinosis to augment this. So this is really our technique. And this does really quite well. You can see the fixation over here. These are the steps of the surgery. The integrity is tested by flexion. You want to make sure that you can flex this in about up to about 45 degrees, and immobilize this in full extension for at least 8 to 10 weeks. Outcomes were that we reduced the extensor lag from a mean of 40 degrees preoperatively to 5 degrees. It's almost rare to get full extension. There was improvement in the Knee Society scores, but the interesting point here was almost all of these patients had some degree of residual pain. They had improvement in the function, but the pain scores did not improve all that much. So the advantages are that it is easily accessible, it can be harvested, there's no donor side morbidity, no risk of disease transmission, results do not deteriorate over time, and the fixation of the bone block does not compromise the use of stems. So this is pretty much what we have. You want to be able to flex this without anything giving way up to about 50 or 60 degrees on the table. And this is our outcome. You can notice here that she has about a 5 to 7 degrees of extensor lag, and this is a fairly common outcome. You almost rarely, if ever, get a full extension. We also did a combined paper with a group from Italy, Andrea Baldini's group, where we looked at the surgical options of chronic patellar tendon, where we compared allografts, Achilles tendon, and our own technique. So these were the three groups: full extensor mechanism, Achilles tendon, allografts. We did 21 cases. These were the three surgical options that were used. The quadriceps tendon that I did, the allografts which our colleagues did. And again, you'll see that the extensor lag decreased from about 50 degrees to 3 degrees. The Knee Society scores improved, and the differences in postoperative extensor lag were not significantly different in the three groups. So our conclusion from the study was that for chronic cases, use the Achilles tendon allograft. Autograft should be used when the host tissue is competent, particularly in patients who are young or post-infection. And when there's extensive disruption of the quadriceps mechanism, they use a full extensor mechanism allograft. So these are some of the historical reports in literature, and pretty much what you get is a compromised function. It is better than we've come a long way. The earlier results were extremely poor, but of late, certainly our outcomes and the ones from the Mayo Group have reported reasonably good results with this. In terms of patellar fractures, if you have an undisplaced, treat conservatively. Displaced fractures, treat by open reduction and internal fixation. The important thing to realize here is you do not want to use any metal, no wires and K-wires. Using sutures is much better. Again, this is the algorithm of the type of fracture, and again depends whether the patella was resurfaced or not and how stable the implant is. So this is a algorithm of the fractures, of the vertical and the transverse fractures, and pretty much this whole talk is really centered around managing the patellar tendon disruptions. A difficult problem, but these are some of the ways that you have to bail out.